Good day.
Do you see the slides?
It does.
Okay, great. Okay, let's start. Good morning, everybody. I'm happy to be here. What I really want to discuss with you today is an overview of bacterial endocarditis. This is the kind of lectures I give to my residents. So let's start. First of all, I want to share this with you. There's no lectures without some. Sorry, I'm using two screens here. Okay, anybody knows what was that? Okay, that's a hummingbird. That's in my backyard. So let's talk some dynamics here. The heart rate of the hummingbird is 250 beats per minute, 500 beats per minute, 750 beats per minute, 1000 beats per minute, 1250 beats per minute. Any guess?
I don't know.
Okay, it is 1250 beats per minute. The hummingbird flaps its wings at the rate of 25 beats per second, 50 beats per second, 75 beats per second, 250 beats per minute, 250 beats per minute. What is this? Hey, one by one, please. This is a 49-year-old man presented with fever and chills of 3 days duration. Blood culture is positive for gram-positive cocci clusters. This is one of my actual patients, in fact. All right.
January region.
Okay. All right. This is my outline for infective endocarditis, native valve endocarditis, a blood culture negative endocarditis, prostatic valve endocarditis, and other cardiac device infections if we can get to it. Native valve endocarditis, we're going to discuss some etiology, epidemiology, diagnosis, clinical manifestations, echo, cardiography therapy, blood cultures negative, and prophylaxis. You know, I don't know what is the epidemiology in Palestine as far as endocarditis. Can someone tell me what is the rate or how frequent you see rheumatic fever nowadays?
We have no data about this.
You have no data, but do you see cases?
Yes, yes.
Oh, you still see cases? Okay.
Yes.
All right. Which of the following is the most common bacterial etiology of infective endocarditis worldwide? Streptococcus mutans, Streptococcus sanguinis, group A, beta hemolytic strep, Enterococcus fecalis, Staphylococcus aureus, methicillin sensitive or methicillin resistant. I need response from the audience.
Yes. That's audience.
Excellent. That's worldwide. You know, the epidemiology is different from one place to another. If you talk worldwide, it is MSSA. If you take developing countries, it is still Staph aureus. When bacteremia is documented, which of the following is least likely to be associated with endocarditis? Streptococcus mutans, Streptococcus galacticus, which is bovis previously, Streptococcus mitis, Enterococcus fecalis, and Streptococcus pyogenes. Excellent. All right. as this table shows, the Staph aureus about 27 to 35%, followed by the streptococci that are associated with endocarditis. Enterococcus can be nasty, really. It is very difficult to treat. Coag-negative staph usually is associated with prostatic valve endocarditis. Okay, the Hasek gram-negative bacilli, polymicrobial, candida, and culture negative. What are the Hasek organisms? There's the old taxonomy and there's the new taxonomy. PhD guys, they keep changing the names on us, but it always gives us the old names. They are oropharyngeal gram-negative cucobacilli, causing subacute endocarditis. So when you talk about acute endocarditis versus subacute, the subacute most of the time is caused by the Hasek group. They usually cause very large vegetations and more embolic phenomena, and almost always they need valve replacements. And remember this, ceftriaxone still is the drug of choice for 4 weeks. The new names, you have Haemophilus aprophilus, Haemophilus parainfluenzae, Actinobacillus, Actinocytomitans, and there's Cardiobacterium. At least this one has a cardiac name, hominis, Echinella cordens, and Kingella kingi. So these are the new names of the new Hasek group, as you can see it. When it comes to IBDU, I don't think you see much of that there, hopefully not. The Staph aureus really is at the top of the list, followed by streptococci. All right-sided 77%. So most of the right-sided endocarditis is on the right side, the IBDU related. Enterococci, it can be polymicrobial, it can be gram-negative, can be candida in certain situations. In developing countries, this is the current epidemiology. What we are seeing now is patients at, older age group, 70 years and above, almost 75% of patients. Sometimes it's like a cluster in the hospital, and sometimes I feel it's seasonal. There's more Staph aureus, there's affecting the aortic valve, more males. Because of the advanced age, there is more degeneration of the valves themselves. So they are more prone for invasion by transient bacteremia like Staph aureus. Patients in this place, they are in and out of the hospital, and they are exposed to nosocomial infections. We have less rheumatic heart disease. I haven't seen a case here. Maybe in some, immigrants, I don't know. There's more prostatic valves being put in these patients. We are seeing less embolic events, more congestive heart failure, and more surgery. Definition of infective endocarditis, pathological criteria, positive cultures or history of vegetation, embolus, intracardiac focus, clinical criteria, 2 major and 1 minor. I don't know about these criteria nowadays with the advancement in the cardiac, especially with the presence of TEE and the advanced culture media. So still, they are good for, from my perspective, for historic perspective. 2 major or 1 major plus 3 minor, possible 1 major, 1 minor, 3 or 3 minors. Rejected alternative diagnosis when the clinical criteria does not fit or there is does not meet criteria for possible. Which of the following is not a major criterion in modified Duke's criteria for diagnosis of infective endocarditis? A typical organism consistent with endocarditis from two separate blood cultures in absence of a primary focus. Antiphase 1 IgG antibody titer for Coxella burnetii, oscillating intracardiac mass on a valve or supporting structure on TTE, worsening or changing pre-existing regurgitant murmur. A response from the audience?
Is the IgG antibody?
Oh, okay. I don't blame you for picking the wrong answer. How do you get Coxella burnetii anyway? One by one, please. What is Coxella burnetii? How you get it? This is a zoonotic infection. You get it from livestock, from sheep, okay? And I wouldn't be surprised that cases are being missed somewhere else. And this is how you diagnose it. And it is one of the causes of culture negative endocarditis. You know, you have a murmur, you have a vegetation, you have a culture negative, you have the right epidemiological setting, the right exposure, and then you do the titer, then here you have your answer. You know, worsening or changing pre-existing regurgitant murmur is not a major criteria, because the murmur can change even without any recent damage. It's all about hemodynamics. When it comes to major criteria for diagnosis of infective endocarditis, blood cultures, at least 3 sets from different sites with first and last 1 hour apart. Echocardiography should be performed in any patient that you suspect infective endocarditis. Do you have TEE in your hospital?
Yes.
Okay, excellent. These are the minor criteria. You know, some of them are as a direct effect of the infection, or some of them because of some immunological phenomena. I am sure you are all familiar with these. Now, when it comes to the first suspicion comes when you have a positive blood culture with an organism that you know that this is a potential cause of endocarditis, then you take it from there. Nowadays, Staph aureus, any patient comes to my service with Staph aureus bacteremia, it's like TEE is down the road. There is no reason not to do it. Very dense group, streptococci, strep bovis. Where do you see strep bovis? Which category of patients?
Cancer.
Excellent. Okay, so you pursue, you go the further step, and you arrange for the patient to have colonoscopy at one point. Enterococcus, usually, most of the time, community Enterococcus fecalis or other enterococci, usually they are community acquired. They have a more indolent course, okay? And you have the HASI group. And usually you look at the patient is bacteremic, and your clinical evaluation does not reveal any focus of infection. So this is most likely a endocarditis. And you know, you start treating the patient and the patient still has positive blood cultures, then this is another clue that the patient has high volume bacteremia because of intracardiac infections. Who's at high risk for endocarditis? Okay, prosthetic valves. There's more prosthetic valves now put a day in this part of the world than previously. People are living longer. People are having a degeneration of the valves that affect their hemodynamics, and then they end up having prosthetic valves. Congenital heart disease. How frequent you see congenital heart disease in your place?
Not common.
Not common. Okay. Previous endocarditis. This is very important. New murmur. Provided that you know the patient. Okay. Heart failure, heart block, and there's other stigmata of infective endocarditis, the peripheral signs, of course. Large mobile vegetations, anterior mitral valve leaflet, valvular insufficiency with perivascular extension, valve perforation, and ventricular dysfunction. This is a case, 63-year-old man with no significant past medical history, presents with a week of fever, rigors, and progressive dyspnea on exertion. The blood pressure, as seen on the screen, high fever, skin and conjunctiva. We'll show you the pictures. He has increased in the jugular venous pressure. He has RALs up midway, loud diastolic decrescendo murmur at the lower left sternal border, and positive Quincke's pulse. He has, what does he have, this patient?
Aortic regurgitation.
Excellent. Yahya is doing a good job with you. All right. These are the laboratory findings, and the TTE shows 1.5 centimeter oscillating mass on a bicuspid aortic valve. And the pictures are on the side. Microbiology reports 3 out of 3 blood cultures drawn yesterday. Gram-positive cocci in cluster. And this is the actual patient, okay? These signs, I always see them in Staph aureus endocarditis, okay? It's like pathognomonic. What antibiotic regimen would you recommend pending further information about the gram-positive cocci? Oxacillin plus rifampin, vancomycin, vancomycin plus gentamicin, vancomycin plus rifampin. One of the audience, please.
Vancomycin.
Excellent. Okay. So you have a patient who has no prosthetic valve, has a gram-positive cocci in clusters in the blood. You don't know this is MSSA or MRSA, so your empiric treatment is vancomycin. Splinter hemorrhages really are, they are good when they are there, but people work with their hands and they could be traumatic. So don't be misled by them unless they are associated with other physical findings and other clinical criteria. Okay, Enterococcus endocarditis. Usually we see it in older men, like the aortic valve, congestive heart failure, and there's more embolic phenomena, lower mortality. This microorganism, although it is hard to treat, but it is not that virulent. So these are some of the common laboratory findings in patients with endocarditis or physical. Worsening old murmur, provided you know the patient, new murmur, vascular embolic events, splenomegaly, splinter osler Janeway, ESR elevation, hematuria, abnormal chest X-ray. You see, sometimes you encounter a microorganism that you think it is susceptible, but you look at the MIC and you see that, okay, this is the bovis, okay? MIC less than 0.12. These are the recommended regimens when the MIC is less than 0.12. So it's straightforward. Vancomycin is put there in the event that the patient has penicillin allergy. When it comes, if the MIC is more than 0.112, How is the microbiology lab at your place? Does it give you enough data to make the right clinical decision about antimicrobial therapy?
Yes, yes.
Okay, all right. So in this case scenario, really, you need to add gentamicin anyway. You know, in the event you have these unusual microorganisms, they call them neutrally variant streptococci. Most of these microorganisms actually come from the oral cavity. So because they are penicillin tolerant, really you need to use combination therapy. This is all you can find on the American Heart Association guidelines. Case, a 58-year-old woman with known mitral valve prolapse presents with 3 months of low-grade fever, chills, night sweats, and 30 pounds weight loss. Over the past 2 weeks, she has developed diffuse myalgias and severe low back pain. She has no allergies. Exam, blood pressure, pulse. She had the splinter hemorrhages, bilateral rough spots, a grade 4/6, blowing hollow systemic mirror radiating from the apex to the axilla. TTE 1.4 centimeter oscillating mass in the mitral valve, anterior leaflet, moderate mitral regurgitation. After 3 days, 6 of the 6 blood cultures are positive for strep bovis. MIC for penicillin is 1 ugram per ml. Which of the following would you recommend as definitive therapy? Ceftriaxone for 4 weeks, ceftriaxone plus gentamicin for 2 weeks, ampicillin plus gentamicin for 6 weeks, vancomycin for 4 weeks, vancomycin plus gentamicin for 4 weeks. You know, this has to do with the MIC. So remember.
Ampicillin and gentamicin.
All right, good job. Have you seen Enterococcus endocarditis at your place? Have you diagnosed any cases? How did you treat it? What regimen did you use?
Enterococcus.
Yes.
Actually, all the patients who have infective endocarditis cultures were negative.
Because of what? What is the most common cause of culture negative endocarditis? You brought a good point, in fact.
Partially treated.
What?
Partially treated before taking enough sample. Yeah, not enough sample for.
No, sir. A prior antibiotics. You said they are all culture negative. Before they get to you, they go somewhere else and they get oral antibiotics. Only few doses of oral antibiotics can render most blood cultures negative in these patients. You know, remember, most of them are streptococci. They are susceptible to most oral antibiotics, especially the beta-lactams, all right? So people go here and there. Sometimes they go to the pharmacist and they get antibiotics because they have fever. Correct me if I am wrong, right? So the most common cause is prior antimicrobial consumption. Okay, this is some of the regimens. Enterococcal endocarditis is not straightforward. Patients need longer duration and need a combination of antimicrobials. And these are the regimens for Staph aureus. MSSA, nafcillin or oxacillin, and cefazolin. What is the issue with nafcillin or oxacillin? This is an antibiotic question. Why we have to give them in very high doses? I'm just sidetracking you, see how much you remember from last time. They are protein bound. 95% of nafcillin and oxacillin or the semi-synthetic penicillins, they are protein bound, right? 95%. So you are talking about 5% of actual active drug. Okay, you give up to 12 grams of these medications. MRSA, vancomycin, daptomycin. Here's my question to you. Do you carry daptomycin in your hospital?
No.
Okay, all right. Well, I'm sure the vancomycin still works. Have you encountered MRSA that is resistant to vancomycin, or in general Staph aureus, like MIC of 2?
Yes, yes.
All right. So what is the alternative? How you treat these patients?
Tigecycline.
No. Tigecycline in the blood.
Yes.
These patients survive. You should not use tigecycline for anything these days. It is a bacteriostatic antimicrobial. You should never use it for bacteremias. Okay. Okay. All right. Okay. It is what it is. I know the situation. Okay. Here's some of the examples of culture negative endocarditis. All right. And you should always think about these. And it all has to do with the history, the exposure, Coxella burnetii, the Bartonella species, Triphonema whipili, and no diagnosis, usually prior antibiotics. This is a series of 348 cases. Okay, here you go. Another audience response question. A 44-year-old man presents with a subjective fever for 3 months, diarrhea for 1 year, lost 30 pounds, and complaints of intermittent arthralgias, mainly in his hands. Vital signs, he has low-grade fever, loud decrescendo, blowing diastolic murmur at the lower left sternal border, and rales halfway up bilaterally. Blood culture 6 set are drawn and remain negative for 21 days. Valvular tissue obtained at valve replacement reveals foamy macrophages by PAS10. Which of the following is the most likely etiologic agent? A member of the HACI group, Coxella burnetii, Triphonema whipili, Chlamydia psittaci, Bartonella species. Huh? What is this? One word.
C.
All right. Okay. You beat me. Okay. All right. I surrender. Okay. Culture negative endocarditis, Triphonema whipili, men, age range 40 to 80, arthralgia. These are the clues. Chronic arthralgias. Prior valve disease. You know, this microorganism really does not attack normal valves. Fever. The only time they do the diagnosis when the patient is post-op. So it's pathological diagnosis, because it's hard really to culture these microorganisms. When you see foamy macrophages on the PS10, that's your clue. Treatment, doxycycline and hydroxychloroquine, 1 year or more. So these patients need long-term therapy. Bartonella quintana usually is homeless. Alhamdulillah, there's no homeless people in our country. We all take care of each other. Valve is normal or abnormal. Lice, possible vector. Culture difficult. Serology helpful. So in this part of the world where I am at, these things might happen, and the treatment is doxycycline with rifampin or 2 weeks of gentamicin. Okay, Coxella burnetii, Q fever, direct or indirect animal contact, hepatosplenomegaly, clubbing, because this is like indolent and chronic, okay? The patient goes from one place to another and missed unless somebody think about it, somebody takes the right history with the right exposure, then that's the lead. Clubbing, abnormal or prosthetic valve, serology. The diagnosis is by serology and by epidemiological information. And that's the treatment, doxy plus hydroxychloroquine. Other causes, aspergillus, usually the patient is immune suppressed. It's not difficult to culture aspergillus. It's very easy. And the leptomenan serology. The most common cause of culture negative endocarditis, prior antibiotics, okay? Chlamydia psittaci, Legionella species, acute rheumatic fever, Lippmann-Sack endocarditis, you see that with this LE, atrial myxoma. Routine cultures nowadays in the right setup with the right technology, you can grow them. All right. When you really take these patients to surgery, any questions? Looks like you know most of this stuff.
I think clear.
Okay, good. When you do surgery, heart failure due to valvular dysfunction, endocarditis from fungi or MDRO marker. When you have multi-drug resistant microorganism, that is a big problem, okay? No matter what you do to these patients, no matter what antibiotic regimen, the cultures remain positive, then you have to get rid of the source. And the only way is by surgical intervention and valve replacement. Presence of heart block, when the infection extends beyond the valve into the intracardiac tissue, causing abscesses and conduction defects. Persistent bacteremia. When you have persistent bacteremia and you did everything possible for these patients, all the imaging studies did not reveal any other focus that you can deal with and eliminate. When you have a large vegetation and you have embolic phenomena, especially to the CNS. These are the indications for early cardiac valve surgery: heart failure, refractory, pulmonary edema, cardiogenic shock, obstruction, fistula, aortic valve or mitral valve regurgitation or dysfunction with poorly compensated hemodynamic function, uncontrolled infection. Fungi are difficult to treat, so you are heading to surgery early. And when you have an MDRO pathogens, that's another indication. And when you have persistent blood cultures in the absence of clear focus. Okay. Here's the big question. When you give prophylaxis for endocarditis, there is no controlled studies when it comes to prophylaxis. This is all experience, judgment call, whether it really helps or not, there is no data, okay? And the guidelines are changing, the indications are becoming less and less year after year. Here's the case. A dentist requests a recommendation for antibacterial prophylaxis for endocarditis for a patient with planned tooth extraction. The patient is 60-year-old female with no significant past medical history, except calcified aortic sclerosis. No prior history of endocarditis, no known drug allergies. The best recommendation for management prior to extraction, all 30 to 60 minutes prior to the procedure, is no prophylaxis, ampicillin 2 grams, clindamycin 600 milligrams, azithromycin 500 milligrams, ampicillin 1 gram IV. Audience response?
No need for prophylaxis.
What?
No prophylaxis.
Excellent. Antimicrobial prophylaxis for endocarditis changes from 2008. List of cardiac condition reduced. List of procedures greatly reduced. Regimens simplified. For oral prophylaxis, unless there is gingival manipulation, there is no indication for prophylaxis. You know, I'm going to give this patient local anesthesia. The answer is no. Extraction, no. If you are doing gingival manipulation, then this is one of the indications, provided that the patient has criteria for prophylaxis. Who are these patients who need prophylaxis? Who are at high risk for endocarditis? First and most, prosthetic cardiac valves. That across the board get prophylactic treatment. Prior endocarditis. These are the two highest risks. They are at the top of the list. Congenital heart disease that is not corrected. Unrepaired cyanotic congenital heart disease. Now, if you repair a cardiac defect with prosthetic, then that's another reason. These are the at the lower, lower risk of endocarditis, but within 6 months, these patients needs to be prophylaxed. Repaired with residual defect, there's a defect, so it's very obvious. And cardiac transplant with valvulopathy. And these are the recommended regimens. Drug of choice, amoxicillin. If the patient IV is ampicillin or ceftriaxone. If the patient has allergy to penicillin, clindamycin is the alternative, or clindamycin IV. Okay, any questions so far? We're going to jump to prosthetic valve endocarditis and end up there. Nope, okay. A 70-year-old male presents with fever, chills, and low back pain for 6 days. He underwent bioprosthetic aortic valve replacement 9 months previously for critical aortic stenosis. Vitals, temperature 38. There's left conjunctival petechiae. There's RALS. There's grade 2/6 systolic ejection murmur. Blood cultures 3 of 3 positive at 18 hours for gram-positive coxine clusters. While awaiting TEE, which of the following antimicrobial regimen should be started? Vancomycin, vancomycin plus rifampin, vancomycin plus gentamicin, and later plus rifampin, linezolid plus gentamicin.
Vanco, Genta, and Rifampin.
Excellent. So this is prosthetic valve. So native valve, single agent, except in certain situations. Prosthetic valve, always combination. Why we use combination prosthetic valves? What is the issue of prosthetic valves?
Biofilm. Biofilm.
Huh?
Biofilm.
What? Biofilm. Excellent. So the most common causes early on is coag negative staph. Staph aureus, gram-negative bacilli, enterococci, fungi. These are because of the proximity of the hospitalization. Down the road, the causative agents are comparable to native valve endocarditis. All right. Staph, prosthetic valve endocarditis, MSSA, semisynthetic penicillins plus rifampin plus Genta, MRSA, you replace the NAFs with Vanco and you're good to go. Duration, really 6 weeks is arbitrary, but you have to evaluate the patient at frequent intervals to decide when to stop. Enterococcus prosthetic valve endocarditis really carries a problem. All right. But it is the same as native valve endocarditis, use combination antimicrobials. All right. Implantable devices, how frequent you see them at your place? Like pacemakers, how frequent are being done? Do you have cardiac surgery there? Who does them? Do you see infections? Pacemakers, defibrillators, etc. Do you see these?
Yes, yes.
Okay. Have you seen infections in these?
Yes, sometimes we have to do an extraction of the leads.
You just answer the question. I'm done. You guys are smart. Okay. Okay. Most common microorganism is Staph epi, Staph aureus, can be gram-negative, polymicrobial, etc. 71-year-old male presents with fever, chills, and pleuritic chest pain for 4 days. A permanent pacemaker was implanted 15 months ago for 6 sinus syndrome. Has fever, generator pocket, CDI without warmth or erythema. Scattered rhonchi and tour rub in right base, no murmur or cutaneous findings of endocarditis. 3 of 3 blood cultures are positive at 24 hours for MRSA. Chest X-ray shows nodules and pleural-based lesions. Echo shows 7 millimeter lead vegetation in the right ventricle. Which of the following is the best management? Remove generator plus Vanco for 10 days. Remove leads plus Vanco for 2 weeks. Remove entire device plus Vanco 2 weeks. Remove entire device plus Vanco for 4 to 6 weeks. Remove entire device plus Vanco, rifampin, 4 to 6 weeks. This is just clinical decision making. So you have a generator, you have a vegetation, and you have positive blood culture. What is the optimum decision here? Okay.
As cases of native valve endocarditis, plus to remove the entire device.
Remove the entire device. Thank you.
Right.
There's no compromise here. It's really, you cannot treat these patients with just antibiotics. The hardware has to be taken off. Okay. So survival with or without device removal. There's better survival with device removal. Okay, this is the American Heart Association guidelines. Blood cultures before antibiotics, if positive then PE, gram stain, pocket tissue, lead tips, etc. Device removal for all infections and occult staph bacteremia. Consider for gram-negative RAS bacteremia. Therapy, antibiotics based on susceptibility. Pocket, only if the pocket is infected. Duration is 2 weeks. Bloodstream infection, this is a judgment call, clinical decision, more than 14. Lead or valve vegetations across the board, up to 6 weeks. If the patient needs the device, when you do it, okay? we get consults, clear this patient for device reimplantation. We get this all the time. So when you do it, these are the guidelines from the American Heart Association. Negative blood cultures more than 72 hours. If endocarditis, reimplant 14 days after antibiotics, blood cultures negative. And prophylaxis, always prophylaxis before implantation. All right, any questions?
Thank you.
I need one more favor from you. That's my email. Kind of send me your names so I can interact better this next time. Call you by name if you are present, and give me suggestions of topics in infectious disease you need to discuss. This is my format always. What I do here, I do for my residents, okay? And I need feedback, positive or negative, so I'll be much appreciated. Okay, the best of luck, guys, and God be with you. All right?
Thank you. Thank you.
You're welcome. سلموا على جميع الزملاء وخاصة الدكتور يحيى.
يصل يصل.
بس شكرا.